express my sincere thanks to the organizing committee of ABNFC to give me an opportunity to present an interesting case about the overlap of disorder of the brain interaction. Now let me introduce the patient, a 43-year-old Vietnamese male with a 5-year history of GI symptoms, including heartburn, fullness, and diarrhea, presented to our outpatient GI clinic. The symptoms started 5 years ago and then rapidly worsened over the next year. The onset of symptoms included epigastric pain, alternating diarrhea, and constipation. He was diagnosed with HB infection on his first endoscopy. After successful eradication of HB infection with bismuth-containing pharmacotherapy, heartburn, problems, and nausea occurred and did not respond to PPI therapy. After an episode of acute gastroenteritis and NSAID use, the symptoms rapidly worsened and persisted for 1 year, despite PPI, antihistaminic, osmotic, and SSRI therapy. I will present treatment symptoms in detail. The patient reported a burning sensation behind his sternum 2 to 3 days per week. He also experienced about the proper sensations, nausea, but no regurgitation or belching. He had poor sleep due to nocturnal regurgitations. His gut questionnaire score was 8, FSHG was 14, and RSI were 9 points. His fullness sensations was localized in upper abdomen and mainly occurred after meals. The intensity was mild to moderate. The discomfort happened at least 3 to 4 days per week, and he also felt an epigastric burning sensation occasionally. He had an episodic diarrhea with the blood mucus or undigested food, 3 to 4 per day. Response to score was 5 to 6. Diarrhea happened 3 days per week, and on the other days, the power of movement was normal. Neither bloating nor nocturnal diarrhea was recognized. He had a generalized episodic dull abdominal pain 2 to 3 days per week, with the intensity of 4 out of 10, and the pain was sometimes associated with power of movement. Food was one of the triggers of symptoms, especially after large meals, spicy food, processed snacks, carbohydrates, and carbonated drinks. The symptoms peak within 15 to 30 minutes after eating and often lasted beyond 1 to 2 hours. Heavy workload, interpersonal stress, and non-compliance with treatment also contributed to the severity of symptoms. His review of symptoms was unremarkable. No alarm symptoms were noted. He had a past medical history of arthritis, acute gastroenteritis, but no thyroid disease. His medication included antibiotics, NSAID, SSRI, and the osmotic as needed. He worked as a farmer. He drank alcohol occasionally. His family history was negative with GI cancer, IBD, or similar GI symptoms. The physical finding didn't show any abnormal, except mild tenderness to palpations of knees. At that time, our provisional diagnosis was blood, functional dyspepsia, and diarrhea predominant IBS, mainly due to post-infections. In the differential diagnosis, we also consider reflux hypersensitivity or functional heartburn, peptic ulcer, parasitic infection, or hyperthyroidism or microscopic colitis. We need some investigations such as EGD, lower GI endoscopy, pH impedance monitoring, HRN, stool testing, and thyroid function test to confirm and rule out this diagnosis. EGD show reflux esophagitis grade 8 according to Los Angeles classifications, with IFS and Q classification grade 3. There was no other lesions in the stomach and duodenum. The urotest was negative, and there was no evidence of UE on biopsy. HRM showed ECG type 2, with normal IRB in both supine and upright variation. There were no disorder of peristalsis or ECG outflow. BH impedance monitoring of BBI showed total AAT less than 1%, with the master score of 1.6 and high NNDI. There were 57 total reflux episodes, most quickly assigned. There was no association between reflux and symptoms. CBC, thyroid function test, and fecal paratectin was normal. Stool testing was negative with over 6 parasite, acrylocyte, and leukocyte. Colonoscopy was normal, and there was no evidence of macroscopic colitis on biopsy. With the symptom of heartburn unresponsive to PPI therapy. No evidence of UE or GERD on the upper endoscopy. AAT less than 4%, and negative reflux symptoms association. Our definitive diagnosis was functional dyspepsia, overlap functional heartburn, overlap functional dyspepsia, and IBSD. Before treatment, we carefully consider all aspects that can affect the strategy of management, including subtype, comorbidity, and features. Our management plan focused on personal life, education, and lifestyle modification. We explained the patient about the DGPI and the overlap of DGPI. We also advise the patient stop and set, eat regular and smaller meals, reduce triggers, and avoid a prolonged restrictive diet. For pharmacologic treatment, we match mechanism and predominant symptoms. There were 4 mechanisms in this case, such as visceral hypersensitivity, imbalanced transit of gas, on-target marrow powder, and psychosocial factors. Therefore, we chose TCA, prokinetic and probiotic. Because the symptoms were transiently relieved, we add on rifaximin and PPI on the therapy. At the 3-month follow-up, the patient achieved adequate symptom control and get a better quality of life. In this case, I would like to raise 3 clinical questions. First, should PPI and rifaximin be used as adjunctive therapy? Second, what is the role of a low FODMAP diet, cognitive behavioral therapy, and gut-directed hypnotherapy in the management of IBSD and FB? And last, which neuromodulators are recommended in this setting? Before wrapping up my presentation, I would like to share my view on the overlap of DGPI. As we know, overlapping DGPIs occur in 40% of patients. The more severe symptoms are, the greater psychological burden is. Currently, there are some gaps in our knowledge about the overlap of DGPI. We lack a full understanding of pathophysiology of the overlap of DGPI and the definitions of severity of symptoms. We also have many difficulties in diagnosis and multidisciplinary treatment. And lastly, we did not consider overlap DGPI and organic GI diseases or non-GI diseases. Therefore, I think that we have a lot of work in the future. And for me, I look forward to updating the information from overlap in DGPI working team in the 6th Growth Foundation next year. I would like to acknowledge the contribution of our mobility team from UFC, HUS, and Taman Hospital. And this is the end of my presentation.